All right, welcome to ACM, the part 5 of this 6-part series on the ACM assessment. We're going to cover sitting rotation today, and let me share the screen for the presentation you'll get. So sitting rotation is the 5th assessment in the ACM assessment program, and in the sitting assessment pattern, we're actually looking at the thoracic rotation mobility contribution. By having someone sit, we're actually negating or taking out the effect of any pelvic rotation, knee, hip, any lower extremity rotation, and also in some ways the lumbar spine, only because of the lack of rotational contribution it does have, but there are some. So we'll talk about that as we go through. Sitting rotation assessment is a unilateral assessment. We're looking at both sides, right to left, through the transverse plane, rotational plane. We're looking at thoracic rotation. We can add to it some lumbar rotation contribution. We're also looking at that center of gravity distribution that we talked about in the standing rotation. It's not going to be as significant here, but it does have influence. We'll talk about all those patterns as we go through this. When you're using the software, I'll go over that right now. The sitting rotation sitting rotation pattern assessment, you're looking at left and right side, like we talked about, asymmetries, and you'll have an option. You're basically looking to see that someone can rotate their torso sitting in a chair. We'll go over the specifications on this. Actually, I'll just show you. Sitting in a chair, you want to have a person's knees together. I usually have them holding whether I have them holding a block or a pillow, or just having something that they squeeze with their knees, even a piece of paper. We just don't want the knees to slide. If the knees slide or the pelvis rotates, we know we're not getting full rotation, a measurement. We're getting some of that hip contribution and lumbar spine. So somehow securing their knees together, and the best way is to have them hold something with their knees, feet together. And then you're just looking to see how far their torso rotates to one direction or the other. You can use a dowel or a stick so you can get an idea what perpendicular is to start with. Then as you rotate, you're just kind of getting that assessment as to how far you're going right to left. And we're looking for symmetry, obviously right and left symmetry, as well as are they getting to that 45-degree angle. And there are you can do going hammer measurements. There's some other studies out there that are using measurement devices to look at exactly how much rotation you get. For the scope of this assessment, you can tell when someone gets 45 degrees if they're restricted or if they're really past 45 degrees. It's pretty obvious, and you just have to get used to seeing this a few times, and you'll start really getting a handle for looking at that assessment. So moving on, like we said, it's transverse plane. When it comes to the software, we're just asking now, are they able to rotate toward their left side to 45 degrees, yes or no? In this case, it's a yes. And the right side, yes or no? And in this case, it's a yes. And if they have any discomfort or anything experienced, we can add that in there. So that would result in a functional pattern, right and left both at 45 degrees. Someone who's able to rotate, not able to rotate both directions, 45 and 45, right and left, if it's even or if it's restricted but both are at less than 45, then we would consider that dysfunctional. It's symmetrical, which is a good thing, but it's dysfunctional because they're not getting 45 degrees. And again, because it is asymmetrical pattern assessment, we're also addressing right or left. And a lot of times what you'll find is someone who has asymmetries in ankle mobility, someone who has asymmetries that you identified or observed in their toe touch or their backward bend or even their standing rotation, you're going to find those asymmetries here. And so be very aware of that. And so in this case, we've got a yes on the right and a no on the yes on the left and no on the right, or you can reverse those, but that would result in asymmetrical dysfunction. Pretty straightforward here. Again, we've talked about the pattern, the order of this ACM assessment, and there's a specific reason why we go through this order, because each one of these is building on the next. We started with ankle mobility, toe touching pattern, backward bend pattern, standing rotation pattern. Now we're on the sitting rotation. And there's a reason why these are in a specific order, and the knowledge you're gaining out of each one of these assessments to build on to the next one gives you some insights to what we might predict to find in the sitting rotation pattern. And that's what I really want to talk to you about in more detail. So if we looked at Ankle mobility, any asymmetries in ankle mobility that we find, or restrictions in ankle mobility, definitely can contribute to thoracic compensation and restriction in one direction. It's all linked, obviously, but a more direct view of it would be from the toe touching pattern. If you find someone who's, whether they can touch their toes or not, doesn't matter, but if you're finding that big kyphotic rounding of their upper back, it's definitely something to take note of, because you're going to find that it may contribute to restrictions in backward bend, like we talked about, as well as the sitting rotation. If someone is tight in thoracic flexion, they're locked in thoracic flexion or kyphosis, they're not going to have a big ability to rotate in the thoracic spine. So when I find people that have a restriction in thoracic mobility, or actually the kyphotic posturing, like these toe touching patterns show me, I'm going to pay attention to that sitting rotation pattern and see if the pieces come together in that sense. For restriction in the thoracic back. I'll talk to you more about that. We also looked at the backward bend pattern, and this top picture is just a great example of someone who's got great hip extension, as our protocol says, that ASIS should pass over the toe, and then you can see the symmetry of her spine, not just her lumbar spine, but starting out in the shoulder flexion, because that's one of the components we look for, and then following through that on the backward bend, she gets really symmetrical movement out of her entire spine. That's what we're looking for. You find that in someone, you're going to predict to find pretty good thoracic rotation mobility as well. If you don't find thoracic extension specifically, you can start predicting that you're going to find some restrictions in that rotational pattern. So this lower picture shows that those variations. And even though the girl at the very end in the blue suit looks like she's got crazy range of motion, if you really look at where she gets it, she's got good hip extension. I would give her a plus there. But if you look at the lumbar extension versus her thoracic compared to the girl up top, she's got most of that extension component coming from her thoracic back. Now, she may have great range of motion in her thoracic back, but that's a key in the backward bend pattern that's not a symmetrical pattern up there, and that's why we're using the sitting rotation pattern to confirm that she has great mobility. If she doesn't, then we know that there's some restriction there. If she does have great mobility thoracically in the sitting rotation, then the backward bend, it just shows a lot of joint laxity or instability. You can see the same thing in the girl in the red. She's got that kink right in her lumbar spine, and both the men, they've got great hip extension. The one with the shorter shorts on here, he's got a little more symmetry. It's not all defined in his lumbar spine, but he does go a little straighter. The guy here at the front got great hip extension, and he's very flat through the thoracic area. I wouldn't say he's got as much lumbar or thoracic extension as lumbar. So anyway, these are just cues to say, what do you think I'm going to find in the sitting rotation pattern? And it puts the pieces together for you, okay? Again, the backward bend pattern looks at all these different components. We're just paying attention to, again, more than one thing. When it comes to standing backward bend, we want to look at what that thoracic back is doing, because it's going to give us prediction to where we're going with the sitting rotation. Just another example, what to look for when you start the backward bend. We talked about this in the backward bend pattern, but when we see compensation in that lumbar curvature, it's telling us two things. They've either got restriction in, well, it tells us a couple things. They've got restriction in their thoracic back. It doesn't go into extension. They've got restrictions in shoulder mobility, and that's what we'll be able to differentiate later in the assessment with the sitting rotation and shoulder mobility pattern. Or it could be a center of gravity problem, or just joint laxity altogether. But again, the keys to looking at assessments are kind of predicting what the next one's going to tell us. Just what it is, but they all kind of blend together to give you some idea of what's going on with this person. Here's an example of thoracic restriction, or is it shoulder girdle restriction? We don't know. Both pictures, in fact, the websites I got these from, the guy throwing the ball up at the wall was illustrating that this is a good pattern, but you can see how he doesn't truly get shoulder flexion when the ball goes over his head. He's getting a lot of lumbar extension, a lot of hip extension through that to grab that ball as it's falling down. And so is that truly a good pattern to reproduce? I wouldn't think so. I would test him first to see if he's got restrictions in the shoulder, or if he's got restrictions in the, is it a restriction in the shoulder, or is it restricted in the thoracic back, and then move it accordingly. Again, our goal is to figure out what exercises people should or shouldn't be doing. The other picture of the gentleman in the red shirt is it was the example of what poor thoracic extension could create in a high-level snatch movement. And again, with good shoulder flexion and good thoracic extension, go ahead and do a snatch. But if you don't have one of those two components, you shouldn't be putting someone in a snatch position or any kind of overhead position until you've determined, is this thoracic, is this shoulder girdle restriction. But just looking at the movement doesn't tell us. We have to know a little bit more about how to assess that and break those two components out. So you understand we're looking at the difference between thoracic extension and shoulder girdle restriction. You're going to see the same functional movement, but we don't know yet which one it is. And that's one of the key into that. That's why the sitting rotation pattern is so critical to understand, as well as the backward bend. We also talked about standing rotation as the center of gravity distribution. And so when someone rotates and their body falls off that line of axis, like this girl is, she tilts forward slightly. It's not really a forward, it's kind of a lateral flexion, rotation, and side bend, forward flexion, side bend, rotation is kind of all three components involved, all three planes of motion. But as you see someone do that, there's a lot of reasons for this. It could be the restrictions in the hip are forcing her to reestablish balance and fall over the side. Could be a restriction in her thoracic back that doesn't allow rotation, and she has to find it somewhere else by falling to gravity. So the point is, this center of gravity distribution shift could be an indication that we've got something in the hips, and you'll see that in the standing rotation. And through the other assessments, you've kind of narrowed down, is this a hip problem? But if you see this, I would start looking at predicting that there could be something going on thoracically, and that's why we're going to do the sitting rotation afterward. We talked about finding those asymmetries in the bilateral movements. We talked about the ankle mobility restrictions. If there's an asymmetry, that's going to contribute all the way up the kinetic chain, and it definitely ties into the thoracic area. Can definitely tie in the thoracic area, so don't ever minimize that. But more so when we do that bend over toe touch pattern, we're looking at that plane from the front or back. We're going to see, if we see those asymmetries, well, those asymmetries are going to come out somewhere. They're going to come out either in the sitting rotation pattern, the ankle mobility, or the standing rotation. And I'll tell you, a lot of times when I see the thoracic compensation offset or any musculature girth difference, you're usually going to find that in the sitting rotation pattern. So again, everything we've done up to this point has built to kind of predicting what we're going to find in the sitting rotation pattern, and it confirms what we're thinking all along. So it's just that end component to the entire assessment. With the ACM assessment progression, again, we talked about this, the ankle mobility, toe touch, backward bend, standing rotation, and then sitting rotation. There's a reason why you have them in an order. It's not just to keep it consistent, but it helps build your knowledge of that person's movement pattern dysfunctions. And each one of these is looking at different components, but again, they're all tied together. So I just want to keep refreshing you on that concept. Like we talked about, the sitting rotation is a thoracic rotation component, but in toe touching, we're looking at the component that the thoracic back goes into flexion, as well as thoracic back goes into extension. And I'll tell you, when it comes to the lumbar, the spinal column, movements are not generally isolated. They're usually through a pattern of three planes of motion. So we're not going to get side rotation or side flexion without some rotation. And so just keep that in mind. I just really want to emphasize how important it is to be using the patterns to kind of help predict and see what's happening with the other patterns that are going on. And that's why this assessment is so valuable, the ACM assessment. The elements of the sitting rotation pattern. So obviously, we've talked about it. We're looking at that thoracic rotation component. We're also looking at lumbar contribution. How much, and again, there's a lot of stats on range of motion with the lumbar spine, but if you look at the orientation, and we'll look at this in a second, the orientation of those facet joints as they start from either the cervical or the lumbar spine and move upward or downward, the orientation goes from flat, vertical to relatively horizontal. So in the lumbar spine, those facet orientations are vertical, which means they're not going to contribute a lot. They don't like a lot of rotation, and I'm going to show you some complications that come in with that in a second. But you are going to get some rotation there. If we see excessive rotation in lumbar and it elicits pain, then it could definitely indicate a thoracic tightness as well. And just keep that in mind. If you're seeing excessive lumbar rotation versus thoracic, we were already kind of isolated that throughout the rest of the assessments, but you're going to reconfirm it here. And then obviously the center of gravity orientation, if you see them offset, it's because they're getting away from a compensation. It's pretty straightforward. You can see that in a second. And also pelvic stability. How well are they able to stabilize the pelvis and rotate from the torso alone? If you see someone's really struggling and their knees are sliding, one knee slides back, that means they're rotating, trying to rotate from the pelvis and the lumbar spine, which shows whether they don't have the movement pattern established for the thoracic back, or they don't have that stability in the pelvis to support the load of the thoracic spine on the body in a sitting position. So it just gives you a lot of keys to start paying attention to in each one of them, not just a quick assessment of the thoracic back here. We're looking at how the body performs that and what they're doing to possibly compensate. We try to minimize as much compensation in the assessment as possible, but it's important for you to understand how to identify those compensations so you can identify them in higher movement patterns. This is just another example. Just like standing rotation, we're just looking essentially down from the top. How far does that bar turn? You'll start getting a good sense of what 45 degrees is. Just imagine where they start and where their knees are pointing is a perpendicular angle, and that bar should come about halfway. That's 45 degrees. There's a lot of research that, and it varies. I've gone back and forth through this, but thoracically, flexion is between 20 and 40 degrees. Extension is between 25 and 45 degrees. Again, this is why we look at that contribution. We want to see symmetry of the lumbar spine and the thoracic spine and extension in the backward bend, because the lumbar spine can go into about 45 degrees extension. The thoracic spine should match that. So you want to see that symmetry. Lateral flexion side to side. We don't do a lot of assessments with that portion, but the rotational pattern between 35 and 50 degrees. And so I've seen some literature like this one on the bottom says rotation is at 30 degrees on the lower end of the spectrum. This study talked about between 35 and 50. So I just look at that mid-range, about 45 degrees is what we're trying to achieve. It's a good guess. We're not measuring specifically, but you can tell someone that's really tight and doesn't probably even get to 30 degrees versus someone who gets to 60 degrees. And I circled this because extension being 45 degrees, I wanted to mention that it's comparable to what the lumbar extension is, as well as the thoracic rotation. The thoracic spine is meant to move in all directions versus the cervical spine, which is really predominantly more rotational, and the lumbar spine, which is really more flexion extension. This 18 degrees, 0 to 18 degrees, 18 degrees is on the extreme end of that range of motion. We do not really want to see a lot of that range of motion in the lumbar spine of rotational components, and I'll show you why right now. If you've ever heard, and again, this isn't a medical assessment, but you will come across people who have had quote-unquote Scotty dog fractures. I'll explain that in a second. They're called pars defects. You hear this about with spondylolisthesis or spondylolysis, and that's essentially the lumbar vertebrae that slips forward, or it rotates on itself. I'll show you this in a second too, the musculature. But what it means is when you look on an x-ray, it's kind of neat. And unfortunately, say it's neat, and someone has to endure the pain of this to make it apparent for us to look at. But on an x-ray, the angle that they take the x-ray at, you can see where this line says the loosening of the pars interparticularis. The vertebrae has the spinous process and the transverse process, and the connection between those is the pars. The bone that comes up that is the superior facet joint that meets the inferior facet joint of the bone above the vertebrae. Well, this image looks like a dog and the collar of a dog, so that's why they call it Scotty dog fracture. Now imagine if the lumbar spine's facet joints are orientated in a vertical position, and the facet joints are touching each other, and they start to rotate, they're pushing against each other, and this can cause the fracture of that pars, the pars of the vertebrae. And that's typically where the fracture occurs. So anyway, the point of all this is the lumbar spine does not like to rotate. The lumbar spine likes to go into flexion extension. Lack of rotation from the hips, lack of rotation from the thoracic spine contributes to more rotation of the lumbar spine, and this is where some of these problems can come and manifest. How do you address that, especially as an exercise therapy specialist? Well, you're not a doctor, you're not doing surgery, you're not a clinician, well, you may be, but we have to understand that we're not fixing someone's back. We're not doing surgery. We're not doing rehab. We're addressing the dysfunctions that lead to these problems. So someone could have a significant problem. In fact, with these type of injuries, they usually don't do much for treatment other than stop doing the activities that are causing stress. And that's where we can step in and say, look, we have a whole program that can address this. But if you do have someone with a pars defect, spondylolisthesis, or something related to this bony fractures, or the spondylolysis or listhesis that this vertebrae is slipping forward, you have to start really paying attention to mobilizing, or not mobilizing, but stabilizing the lumbar spine in the movements that are happening, because these people are going to want to cheat and twist their hips and knees. This is why when we do the assessment, we want the knees flat together. When we do certain exercises, you want to really pay attention to how much lumbar rotational contribution is coming from the movement you're trying to achieve with thoracic extension. We'll look at that later. Hopefully that makes sense. Limitations in thoracic rotation, and gosh, I'll tell you, this could be a subject in itself for an hour, but we have to look at it in two ways. You have all the ligament structure that supports the spinal column, which is tremendous. Add to the thoracic spine the rib cage attachment. You've got 12 vertebrae that have ribs attached to it that connect in the front and in the back, and obviously to support and protect the vital organs, your heart and lungs. That also creates some limitation as well. And we tend to think that the thoracic, the rib cage being something, insinuates something rigid. It actually has a lot of flexibility. You know, your entire costal cartilage, your entire rib cage is attached to cartilage, which is flexible on the sternum, as well as in the back through a lot of ligament support. But it's just more ligaments in the back of the spine on the thoracic back that support the spinal column with the rib cage attachments. And this image gives you a little bit better picture of that spinal ligament contribution with the ribs. It just means that if there's some ligamentous rigidity, there's a lot more of it in the thoracic back, and the longer we're in a certain posture with the thoracic spine, the tighter those ligaments can get. This is a anterior portion. This is the anterior longitudinal ligament, and I'll tell you, in gross anatomy dissection, it was one of the most impressive things to see the actual real humans anterior longitudinal ligament. It's a ligament that runs the entire spinal column from the top down, in front of the spine, and so it holds the discs in place and supports the spinal column. We have a small one, posterior longitudinal ligament, that runs the column inside the spinal canal in front of the spinal cord. But the thickness of that anterior longitudinal ligament that runs up the front, it was almost like a thick leather belt that ran all the way up. Incredible strength that ligament supports the spinal column. And that goes to the point that if someone has poor posture, kyphosis, or even stuck in those positions, that ligament structure stretches, and we get very hypermobile in that stuff, and that's where we can run into a lot of problems. But anyway, going back to this, so T-spine restrictions can come from joint capsules, ligament structures, kyphosis, scoliosis, all the posturing that we see, and the ligament structures that contribute to that, as well as the joints, can become tight, just like any other joint in the body. In fact, there's no difference. It's the same type of synovial capsule joint. And so keep that in mind. This is why I'm a big fan of, especially the only time I'm really a big fan of foam rolling is when we use it as a joint mobilization technique to actually stretch ligament structures. And that's why foam rolling, I'll show you the pictures and the exercises. Foam rolling for the thoracic spine is a great way to create mobilization of those individual vertebrae and to start getting some movement of the spine at the capsular level, at the ligament level. Torso musculature, and it's vast. And I'll tell you that your diaphragm, we're going to look at that in a second too. Your diaphragm is a huge muscle. It's a skeletal muscle. It's controlled by the autonomic nervous system, which means you don't have to think about it. But that muscle is what helps contract and expand the rib cage. And breathing is a huge component in thoracic mobilization. You have to take that into account. We're going to talk about that. But the diaphragm muscle is one component to that. Someone who's in that rounded, slouched posture that, you know, we call it the desk jockey posture, that rounded shoulder posture, their diaphragm muscle, a skeletal muscle, if it's held in a shortened position for a long period of time, that muscle is going to get tight. It's not going to want to relax. It's not going to allow the rib cage to expand. When we breathe in, the rib cage actually, the diaphragm actually it relaxes, and when we exhale, the diaphragm contracts. That's what pushes the air out. I'll show you an image of this. But if that muscle doesn't work, doesn't move through its range of motion, and it's stuck because of our posturing, then that muscle becomes inhibited, or it can become inhibited, it can become tight, and that's where people have restrictions in breathing. And so a great thoracic mobilization exercise is simply just teaching someone how to breathe correctly, releasing the diaphragm to start working again. We'll get into that. Intervertebral muscles and the erector spinae muscles. I think I have some slides. Yeah, I have some slides specific about those, so I can show you the difference. But basically, all the back muscles that support the spinal column, the big movers and the small little proprioceptive muscles and rotators. And then again, the contribution that the center of gravity has, the distribution of that, the lack of internal external rotation. You know what? I think. Sorry, this is not right, but just the center of gravity distribution alone, and again, that comes from compensation, weakness, all the things, but it can actually lead to the body becoming tighter. So I don't ever look at the thoracic back as independently tight. I have to think of the thoracic limitations, or limitations in thoracic rotation or mobility of the thoracic back, as a compensation. Why did that get so tight? What's lacking somewhere else in the kinetic chain that's causing this? And so I'll look at that center of gravity. If I see a big center of gravity shift in those other assessments, I'm going to start keying into saying, why would all these other muscles become so tight? And again, a lot of the thoracic limitations of thoracic movement, rotation and extension, are focused on stretching, mobilizing, moving these muscles, but it doesn't tell us why they got tight in the first place. And some of it can be related to this person's posture, sitting all day, driving in their car all day, or it could be a result of lack of stability somewhere else. They have to find stability elsewhere. We'll talk about that when we get to the exercises. I showed you the slide on the ligament structural support. I want to just give you an indication. When it comes to the thoracic spine vertebrae, there are not just two facet joints. You have a superior and inferior facet that meets the superior and inferior facets of the other vertebrae, the blue ones. But the red ones are the rib cage attachments and the articulations that they have with the vertebral body and transverse processes. So there, like I said again, it's not just the two facet joints we're thinking about like we do in the cervical and lumbar spine. We're talking about the rib cage attachments and the articulating surfaces that they have with the spine. So they can get very tight, especially with all that ligament structure. There's, again, another reason why I'm a big fan of mobilization of the spine through foam rolling and things like that to start a program with. We'll get into the anterior fascial lines and the muscle contributions to all this, but I showed you this in the last few presentations, the backward bend, the toe touch, the standing rotation, but this anterior fascial line, again, the connections. Why would someone's thoracic back get so tight? Is it because of restrictions or tightness or compensation from the lower extremities, lack of stability or restrictions? And that's usually the case, but again, you can almost predict certain patterns of the body's movements or lack of movement, because if we're talking about rotation of the thoracic spine, that means this entire fascial line has to move, or what you'll actually feel is tightness in someone's adductor. Someone will feel tightness in the adductor in a certain position when they rotate to the opposite side. So again, the connection is very strong. It's a strong fascial connection of the pecs, the obliques, abdominals, and the adductors. This is just, again, looking at that contribution of the obliques, mostly abdominals as well, being a flexor. The rectus abdominis is just a true flexor. It doesn't have any contribution to rotation. That's our responsibility of the internal, external, and transverse obliques. Transverse obliques are really more of a rotating component, whereas the internal, external obliques here have more of lateral flexion and rotation component contribution, but they're all attached to rib cage. They all control function and movement of that rib cage. And I will tell you based on what we know with most research, the glutes and the abdominals, including the obliques, tend to be very weak on people. If someone has weak glutes, a big, huge stabilizer, someone has weak abdominals, a huge stabilizer of the trunk, then they have to find that stability somewhere else. If you're not encouraging people to do abdominal exercises, especially oblique rotational patterns, to strengthen those internal and external obliques and transverse obliques, and all you're doing is releasing thoracic tightness, then you're not giving them anything to support themselves with. So really pay attention to that internal, external oblique, transverse oblique contribution that has to stabilizing the lumbar spine on the torso. And as someone who has a lot of rigidity and stiffness in the thoracic back, could be a direct result of lack of internal, external obliques, or just the obliques musculature. Again, we talked about the diaphragmatic breathing. As you inhale, the diaphragm contracts. It's what causes it's what causes the lungs to pull down and suck air in, creating a negative pressure in the lungs that allows air to flow in. As you exhale, that diaphragm relaxes, expands, and it pushes the air back out. The air comes out. So imagine someone in a rounded flex type position. That diaphragm muscle isn't going to contract and relax, and it becomes stuck. And that's why breathing exercises are tremendous for people with thoracic tightness, neck pain, stuff like that. It's something to really pay attention to. Look at the size of that diaphragm muscle. It's not just a flat band across the stomach that separates the lungs from your abdominal cavity. It's a big, flat, broad muscle, almost like a parachute, like this example here. And that muscle is a skeletal muscle, and it has the same principles as a skeletal muscle does in our body. Only difference is it's part of the autonomic nervous system, not the voluntary nervous system. So again, breathing is critical, especially with people that have thoracic tightness will probably have restrictions in breathing too. They breathe their stomach or their chest breathers, accessory muscles to breathe from them. One thing I didn't add in here, I don't believe, in the anterior compartment. We'll look at it, I think, here, but talking about the anterior chain. Now we're talking about thoracic contribution, thoracic tightness, but again, that posterior chain has a lot to do with it, especially when we look at the fascial lines. The latissimus dorsi connects to the lumbar pelvis and the torso, the shoulder. So it's what crosses, and it supports creates a lot of stability in that thoracic back. If those shoulders round forward, that lat can start causing thoracic rounding as well as some other musculature. But the trapezius has a contribution to that. The erector spinae, obviously, the lumbar sacral fascia, that white area, the glutes and the hamstrings, that contribution of that posterior fascial chain. And so I always like to talk about the lower extremity as a contributor to what's happening in the upper back, especially for symmetry, the shoulders that elevate or rotation somewhere. But it's usually found somewhere down the kinetic chain. It's never, unless someone's a avid tennis player or baseball player, and that's what they do their whole life. Very rarely do I find something so isolated to the thoracic back that's the reason why we're having problems or tightness and restrictions. It's usually something down this fascial line, whether it's anterior or posterior. And again, the glutes and abdominals being part of that lower cross syndrome. And you can look in, I think, the anatomy section with our certification program that we talked about Jardin's upper cross syndrome and lower cross syndrome, and how that's what contributes to our posturing and tightness. You have some muscles that are long and weak, others that are tight and constricted. Talking about that posterior chain, getting very specific now, we talked about the lat having this big contribution of support of the lumbar spine, as well as what's happening in the thoracic back. And then we go into the next layer, which is those big erector muscles, your iliacostalis, your longissimus, and your spinalis muscles, and they run from your glutes, from the pelvis to the neck, essentially. Spinalis is very specific in the thoracic region, but these muscles, if you look at them bilaterally, they're extensors of the back. They pull the back up. When they work individually, they rotate. And so that's why we do a lot of rotational patterns, and we see people doing rotational patterns, or even have them stand on one foot. You'll feel the contralateral side, the opposite side, contracting, tightening. because that's what those erector spinae muscles do. I'm sorry, the erector spinae, the large ones. That's what they do. They help support rotation and there's a little contribution to rotation, but they help support that. When we go in deeper into those layers and we start looking at here, those long erector spinae muscles are, then we get into the intervertebral muscles, little guys. This is what most people don't think about or see. I'll give you a better picture of it. This picture down at the bottom here are all the muscles that attach each vertebrae together, and these are the rotational muscles. Now in the lumbar spine, I think this one talks about, yeah, the rotators. These are your multifidi muscles. Right here, the rotators. They're little tiny muscles that attach to the spinous process and the transverse process of each vertebrae segmentally. So we call these segmental rotators. Someone who's hypermobile is usually because they don't have good proprioception of those rotators. These little guys, if you look at the size of these bigger erector spinae muscles, the iliocostalis, the longissimus, and the spinalis muscles, huge ropes. They're designed for lots of work, lots of force. When we go down into the lower levels, the deeper levels, look at these tiny little muscles. These are the multifidi, the rotators. These guys are not designed for high forces. They're designed to sense change of rotation and stabilize that segment on top of each other. But they're not going to kick in proprioceptively if they're not trained to. If we're relying on the big muscles to do that work, this is where this dysfunction comes in. Scotty dog fracture, spondylolisthesis, those types of injuries are usually a result of inhibition of those muscles. They're not working strongly, and as well as the injury can cause inhibition of those muscles to work effectively. And we can't just get strong back muscles. We have to start thinking of rotational patterns that stabilize these small, tiny little guys. They're proprioceptive. As the body starts to tilt one way, those guys kick in and tell the big muscles what to do. They're not designed for thousands of pounds of force like the erector spinae are, and this is where we get in a lot of trouble. So you can actually create a lot of strain in these muscles and inhibition of the movements. Hopefully that's making sense. There's a lot going on in the ability of the spine to move, as well as why it wants to stay in constriction or tightness. And again, the posterior chain, the glutes, take into account the glutes, the hamstrings, that cross pattern of the posterior fascial line. I also included this chart. In fact, what I'll do is I can probably, maybe I'll do it on 2 slides for you guys so that, give me a second here. Let's fix this for you guys. I'll take rid of this one, blow this guy up, switch the order. And so you can see, like I did on the other patterns, I've given you a checklist of musculature of the muscles and their contributions to movement. And I do this not because I'm a fan of looking at isolation, but I'm a fan of looking at muscles' contribution to the whole pattern. And so if this is really specific about upper extremity, the scap movement, humeral movement, and forearm. So this is upper extremity. We're not really talking about the spine, but just so you have some indication of shoulder function and whatnot. But the musculature, it'll help you understand kind of groupings of muscles and patterns of movement, not just specific movements, which muscles working, right? So if it helps you, I have some other charts that I'll include with this. When it comes to the musculature of the spine, we can just look at it as the 3 large erector spinae, and then the small little guys, the rotators, the multifidi, the intervertebral muscles as 2 groups. The large ones, the small ones, split them in half. They contribute together they contribute to extension. Individually they contribute to rotation and lateral flexion, movement and stabilization of that. So I said the thoracic flexion, rotation, the components. Let me just enlarge this for you guys. Erector spinae, the intervertebral rotators, like we just said, the 2 big groups, the large ones and the smaller ones. Rectus abdominis is a big contributor to that forward flexion. So the more ab work someone does, and I will just say this, There is no such thing as an upper ab and a lower ab. I mean, you can say there's an upper bicep and a lower bicep, but when you contract the muscle, you are actually generating the exact amount of force, same amount of force in the lower bicep as you are the upper bicep. The same applies for the abdominals. So if you're doing leg raises, you're not working lower abs as much as you're working upper abs. They're all working. There's just safer and better ways to use the abdominals without encouraging flexion of the torso, because that's, again, abdominal insertion is along the rib line, which is going to forward flex the thoracic spine, and it creates a lot of tension in that. So creating strength and abdominal work in an extended position is really the key. Internal, external obliques. We talked about the obliques, the contribution the obliques have on the movements of the thoracic back and the stabilization of the lumbar spine as the thoracic back moves. Very important. The latissimus dorsi being that big attachment from the torso to the pelvis through the lumbar sacral fascia. The quadratus lumborum, we didn't talk about this, but the quadratus lumborum is a muscle that, here it is, there's a muscle that attaches along the pelvis, and it does have some insertion into the lower 12th vertebrae, which is part of the rib cage, the thoracic back. But it can contribute to tilting, pulling, rotation. And think about it this way: weakness of those muscles, overcompensation of those muscles, can contribute to compensation in the thoracic back that's causing tightness in the thoracic area. And so just keep that in mind. Talk a little bit about the quadratus lumborum. And the posterior lower extremity, again, glute maximus being a big contributor to stabilization, as well as that posterior fascial line, hamstrings, adductors, adductor magnus. They're all contributing to lack of stability up in the torso. And if you really just think about it from a very simplistic standpoint, the upper body and the mass of the upper body is all balanced on, I don't have a picture of the spine, but if you just imagine the muscle stripped away, you got all this rib cage, musculature, bones, everything balanced on a little stick over the pelvis. And so something below has to be stable and balanced for the upper body to contribute. So something happening on the right side, ankle mobility, is going to have an influence on probably the contralateral side of the upper body as well. And it's all about balancing that little torso. I'll show you on my skeleton. Just looking at my guy here, you can see this entire upper body bony structure, as well as the musculature, is only balancing on 5 little vertebrae, the stick on this pelvis that should be level and balanced. So everything that passes from the torso to the pelvis and the pelvis to the torso has a contribution to stability of the upper back. If we don't have the stability below and the lumbar spine, then it's going to create compensation of the upper back to find another way to stabilize. Again, the center of gravity distribution, right? Hopefully this is making sense to you. So let's get into the corrective exercises and how I think about this. I give you guys 6 corrective exercises, but I do think of a lot of other things. One of the other things I was going to mention to you was, I mentioned it earlier, was the difference between, we'll go to this position here, was the difference between thoracic restriction. Is it thoracic tightness or is it shoulder girdle restriction? We talked a lot about that in the standing overhead position, standing overhead backward bend pattern. The first initial part of that assessment was reaching the arms overhead, shoulder flexion. You're seeing restrictions there. You're seeing a change in the way the body's working. We also have to be able to differentiate this, whether it's a thoracic restriction or if it's shoulder girdle. The sitting rotation pattern, if we find someone who looks really horrible in shoulder flexion, it doesn't tell us yet, is it thoracic or is it shoulder girdle, until we get to the sitting rotation pattern, and we can really see. You'll be able to see a little bit of it here in the backward bend. If they're getting good extension of the thoracic spine, then it's probably a shoulder girdle restriction, meaning something related to the upper extremity, the pecs, the lats, the teres major, shoulder capsule. But when we're doing sitting rotation and you see a restriction, or I'm sorry, you don't see a restriction in thoracic rotation, and you saw good extension in thoracic back, you didn't see a lot of kyphosis, then you're starting to think, I'm starting to think, there's really not a lot of contribution to thoracic tightness. This isn't a problem. it's probably in the shoulder girdle, and meaning the lat contribution, the capsule of the shoulder, the actual rotator cuff, pec, teres major, etc. One of our ancillary tests, I guess I could put it in here for you guys, one of our ancillary tests to confirm a lot of this is the, give me 2 seconds and I'll pop that in here for you. I will pop that in, is our shoulder mobility assessment, or a test. Again, I said there's 3 ancillary tests to the ACM assessment. The single leg toe touching pattern, the single leg backward bend pattern, and then we also do the shoulder mobility assessment, which is just an ancillary test. It's just kind of giving us a confirmation that we didn't see any thoracic restriction, but we saw some shoulder flexion problem. If I take someone through an assessment and I'm not seeing a huge kyphosis, I'm seeing great extension and shoulder flexion in the backward bend, and I'm seeing really good thoracic rotation, then I'm probably not going to take them through the shoulder mobility test. I can just to kind of say, okay, do you have any shoulder mobility restrictions? Specifically, this test itself is assessing 3 patterns of that shoulder. The hand that goes up above is looking at shoulder flexion, internal rotation, and abduction out. The one that goes under is looking at adduction, bringing the arm down, shoulder extension, and internal rotation. So you're looking at all 3 of those patterns, but you're really isolating the function of that shoulder girdle versus thoracic extension. Somebody that has really tight thoracic back, very kyphotic, they have a really restricted backward bend, they have a restricted sitting rotation, you're probably going to find some restriction here as well. But as a way to isolate or break out and say, look, I saw you had some really bad shoulder flexion, and this is my example for me personally. I've got adequate shoulder thoracic rotation. I'm at that marker where I'm at 45 degrees, but it's tight, and I can tell it's tight. I've got pretty good extension in my backward bend, but my shoulder flexion is extremely tight. So when I come to this pattern, again, I've had multiple shoulder injuries, dislocation and rotator cuff repair, and I've had a torn bicep and multiple rotator cuff tears in this shoulder. So I'm going to suspect, based on my history, if I didn't know me, and watching my pattern, I'm going to suspect that when I get to this one, if I want to test it, I'm going to see some big restrictions. And sure enough, I do have restrictions. The goal should be to get your fists together within 10 inches. And one way I measure it, the span of my fingertip, pinky to thumb, is 10 inches exactly. I've measured it on a ruler. I'll show you. You can see tip to tip is 10 inches, right to tip. So it's a great little guide for me. You see at the bottom here, 10 inches. It's a great guide for me to just guess, are they within 10 inches? If they are, then I don't put a lot of emphasis on it. If they're not, I know that there's some shoulder stuff I need to work on, or at least take into consideration. But I've also ruled out that it's a thoracic tightness problem. If you find that it's a thoracic tightness problem, then I don't even bother with this. We don't expect to see good shoulder function with poor thoracic function. So I always start with the core first, which is thoracic rotation, thoracic mobility, then move into the shoulder. But if we found good thoracic mobility, then we can start guessing there's some shoulder dysfunction. We can test it with this pattern. Does that make sense? I'm glad I remembered to show you that. So when it comes to corrective exercise, one of my favorite, and I have in the program, I didn't get into a lot of breathing stuff. I wanted to make it simple for you guys, but I definitely would be paying attention to someone's ability to breathe and how they breathe. Breathing should come from the diaphragm, which means if you ever watch a baby breathe, their belly goes up and down as they breathe. Dogs breathe this way when they're sleeping or standing. It's all belly movement. That means the diaphragm is contracting and then relaxing, contracting and relaxing, contracting and relaxing, expanding the abdominal cavity in and out. Someone who's restricted in that thoracic flexion, tight, kyphotic, is going to have a really hard time breathing. So you're going to get accessory breathing. You're going to see Serratus, the scalene muscles lifting the ribs. Those scalene muscles tend to be the muscles right here in front, and as part of the thoracic outlet syndrome. Those muscles are accessory breathing muscles. Deep breath, intercostal muscles. I didn't even mention that in the slides, but your intercostal muscles are all those muscles, the rib bones, the rib muscles that support the rib cage, but they're accessory breathers. They're there to contract under heavy loads of breathing. When someone's breathing and you can see it in their chest raising, their neck tightening, those muscles are overworked. They're not supposed to be the primary mover in breathing. So don't underestimate the importance of getting someone to breathe correctly. So I have 3 positions I'll put them in, depending on the person's posture, depending on their condition, their symptoms, whatever it may be. I may just start them right on their static back and work on their breathing pattern here. Have them put something on their stomach, like a little their cell phone or something, so they have some feedback, and have them feel their stomach rise and relax. Right? You'll be surprised at how many people aren't able to do this, and so it's a great indication to you that you need to spend some time on abdominal breathing. I'll change position to hook lying, where I'll just have them get into this position. It's going to obviously change the orientation of their thoracic back. Remember, if someone's kyphotic, laying on their back is an exercise in itself. It's opening or expanding that rib cage without forcing it, and we'll talk about that in a second. Same with this hook lying position. Now, the next extreme position would be someone lying on their stomach. And I say extreme because someone who's extremely kyphotic, rounded, isn't going to like that extension component laying on their stomach, the old McKenzie exercise. So someone who's very restricted in their thoracic extension and rotation, I may not have them start in this prone breathing position, although it opens the thoracic back up even more. The ground is the feedback for them to feel their stomach, and you can just put your hand on their back and feel where the breathing is coming from. If you feel any movement of the chest, you're going to know that it's accessory breathing. You really want them to focus on abdominal breathing. So really pay attention to static back, hook lying position. Even these can be challenging for some people who are extremely kyphotic. Forward head tilt. You might have to even have a pillow underneath their head to allow them to lay comfortably. But I would spend some time here on a lot of breathing exercise. These people tend to have a lot of upper extremity problems, tightness to their neck, neck pain, neck pathologies, shoulder pathologies, all those types of things, more than just tightness of their back. I told you I was a big fan of thoracic foam rolling for that joint mobilization. I think it's tremendously important, and there's a lot of techniques to this, but basically having someone lay over that foam roller, I actually have one right here, as their back's laying over it, I actually try to keep their hips up and their butt tucked under, so we're not getting the lumbar extension. Remember, someone that's tight in their thoracic back isn't going to like thoracic extension, and that's what we're forcing here on a very defined roll. They're going to get all that extension in their lumbar spine, just like they do when they bring their arms overhead in the flexion, as well as all their other posturing. So I have them really think about glute tightening, tighten their butt and get their low back as flat as possible, and then just let their back hang over that spot, and then segmentally let it go. You can roll back and forth, but I like to stop in one spot and tell them to pull their chest back or their head back, supporting their head with their hands, and not get that lift from their arch of their low back. Pay attention to that. But foam rolling in the thoracic spine, tremendously valuable for joint mobilization. I don't like calling it stretching. It's really joint mobilization. It's really effective. But it's not the only thing I do. I get that mobilization, then we got to teach the spine what to do with it. So I tend to start a lot of people on foam rolling with their thoracic back if they can handle it. If someone's extremely kyphotic, tight in the wrong position for a long time, and they have even a hard time laying on their back on flat, then I'm probably not going to put them on a foam roller. For someone like me, foam rolling for my thoracic back, just to get the mobilization of it, is tremendous. Then I get into getting the spine to move. Cats and dogs is one of my go-tos for just about almost all my patterns, because of what this exercise really entails. Movement of the pelvis, contribution of that pelvis, how it relates to the thoracic spine. And I will tell you, as an assessment tool, the cat and dog is another great assessment tool, because it's not a hard position to move through. Flexion, extension of the hips, thoracic back, scapular positioning, all of those. Having someone do a cat and dog a couple times will give you an indication of where their dysfunction is. You'll be surprised how hard this is for some people to do, and it tells you that they are missing all these pieces to the puzzle. So if they can't even do a cat and dog effectively, pelvic flexion, pelvic extension, lumbar thoracic spine, scapula's retracting and then protracting. If they aren't even able to get through that positioning on a cat and dog, how are you going to expect them to do it at a higher level exercise that you're giving them? They're not going to. They're going to find a compensation pattern. So cats and dogs is a great assessment tool, boy, oh boy, as well as an exercise to set this in motion. Really pay attention to when they go into the movements. People that are extremely kyphotic will just push up through their back and their pelvis doesn't move. They don't really emphasize this lumbar flexion. I have them really focus on thinking about pushing their low back up into the air, not their upper back, even though it's part of it. And when they come down, you're going to see this thoracic back doesn't move. Their scapulars don't move. They stay completely kyphotic, and all they get is that hinge at their lumbar spine. So I have them really think about an anchor tied to their chest, pulling them straight through, and emphasizing that scapular protraction or packing of the scapula. And it really helps unlock that thoracic extension component without forcing the lumbar extension too much. But use this as an assessment tool as well. It's a great exercise to start with. And again, when it comes to rotation, you've got to figure out where your client is at. How much are they capable of and whatnot? The hip crossover is another assessment for me. I use it a lot because it's thinking about that posterior and anterior fascial line. We're connecting the pelvis to the torso. You can see that when someone rotates over and holds this position, the adductor, the oblique, you see the twisting of her shirt, all the way up to that right shoulder is in that anterior stretched position, which is what we want, because most people tend to be very anteriorly tight, that anterior fascial line. So it's a great way, especially if you bring their arm up higher into more shoulder flexion and abduction. But this exercise has a big contribution in the thoracic rotation component without forcing it, because there's a lot of great things out there to force thoracic flexion, but this one here alone is a great way, especially for people that are really limited and are really stuck in that forward flexion position, the anterior fascial connection. It's really important to understand that when you're in this position, as soon as you get the foot on the floor, the hip crossover, you want to press that top knee away from you. When you do that, feel someone's erector spinae of their lower back, you'll feel the opposite side contracting, which is showing the contribution that those erector spinae have in mobilizing rotation of the spine. Such a cool exercise. I love this exercise for people. And then I usually will do some sort of bilateral active frog, because again, the longer I keep someone that's really restricted in thoracic flexion, kyphosis, on their back in extension, and it could be, for some of us, this isn't a difficult position, but for a lot of my clients, just lying on their back is challenging, because if you think of a turtle shell, a turtle doesn't like to lie on its back, right? It would rock. That thoracic back becomes so rigid that they don't like to rock there, and their head just tilts back, their pelvis tilts forward. So the frog, it's one way of getting the thoracic back in extension, and then we mobilize that through the movement of the pelvis. So as the knees go apart, the pelvis actually tilts forward. Think about our toe touching patterns and our backward bend pattern. As we go into external rotation, the lumbar spine goes into extension. As we bring our knees back together, internal rotation, the lumbar spine or the pelvis goes into internal rotation and it flattens. So by utilizing the pelvis in a neutral position to facilitate movement of the spine through flexion and extension, you're actually encouraging the kinetic chain all the way up. Because as the lumbar spine goes into extension, what does the thoracic spine want to do? It wants to go into extension too. So without forcing it, I see too many corrective exercise techniques out there that force extension of the thoracic spine, and you're not going to get it. I'm sorry. You have to mobilize it. You have to get it to move and subtly move it along. It depends on where your client's at in their progression and how much restriction they have. And again, I take a very slow pace at this. And then I'll get into more active thoracic rotation component. Remember, we talked about the obliques. This is a great exercise to activate internal and external obliques, transversal obliques. Really important that you have someone squeezing a pillow or keeping their knees together. Because if they're rotating to the side and their knees are coming apart, where are they actually moving from? The lumbar spine. If you keep the pelvis locked, that rotation is primarily thoracic. And you'll see people that have extreme tightness in the thoracic back, they're not able to rotate very far at all. But it's a great way to facilitate the obliques in this, because remember, the weakness or the tightness of the thoracic back and the compensation is usually a result of weakness somewhere else. This is a great exercise to start activating obliques without really putting a lot of strain on the upper back to their tolerance. So I do a lot of rotational stuff, and I love this exercise for thoracic mobility. Then I move into some loaded positions, and there's a cat and dog position. I don't use this one as much, and I'll share why. You can go into, this is external rotation. Obviously, if their hands above their head, you're going into abduction, external rotation, and flexion. It's more flexion, but external rotation and abduction. But as you're in the cat and dog position, someone can actually compensate and get a lot of lumbar rotation here. So I'll use this from time to time if someone has difficulty with certain things, and I can do an internal rotation of that shoulder girdle too and rotate. It's a good thoracic mobility rotation. See a lot of this. I'm a bigger fan of locking the pelvis in place. So and again, this is a great thing if you think about the anterior chain, the anterior fascial line. If you put someone's feet together, spread their knees apart, they're going into abduction, which is going to stretch those adductors, and then they rotate away from that. You're going to feel the pull on the opposite adductor, that anterior fascial line. This one, you're actually locking the pelvis in place, locking the lumbar spine in place, and truly getting thoracic mobility. So you can test it. Have someone be in a cat and dog position and try to rotate, then get them in this position and have them rotate. They're going to be less likely to rotate here. And this would be more effective at facilitating the muscle activation of that movement. See, through the process, we were trying to mobilize those thoracic areas through the foam rolling and some of that rotation, through passively stretching more of the capsule ligament structures, and then getting into the activation. Once we get some movement there, let's teach those muscles what to do, how to hold those. And so I love the child's pose, thoracic rotation, external rotation, or internal rotation. And you can do it spread foot, forward bend, where you're spread foot, bending over, rotating up. See a lot of that stuff, but it's ways of locking that pelvis in place. I'll actually have some people get into real wide stance for the knees. In fact, I do, because I have tight adductors contributing to that upper thoracic tightness of mine. Once we've gotten a lot of mobilization out of the spine, we know we've got it moving pretty well, then I'll start going after the extension component. But you notice I wasn't forcing extension through any of my corrective exercises initially, because all they're going to do is get extension in their lumbar spine or their neck, or forcing that into the shoulder. Once I know I've got a little bit, then I start going into stuff like the counter stretch. I don't have them reach their hands overhead and lean back, because they're just going to go into what their original pattern was. I put the lumbar spine in flexion as much as possible and have them facilitate that extension. And if you're doing this right, tell people to tighten their thighs and try to lift their tail up in the air, arching their back. And it's really hard to do, especially people that don't have a good toe touch pattern. But they don't have to go down very far. You really want to just pay attention to what they're doing in the thoracic back. And they want to feel muscle activation of the spinalis muscles, the thoracic spinalis, the longissimus, and the iliocostalis muscles. Jesus, talking about big words. You're going to feel the activation of those muscles right in the thoracic region, especially if you can keep them out of lumbar flexion. If someone's got really, really tight lumbar flexion, I have them just bend over further. I bring their hands down to the bottom of that chair just to get out of any lumbar contribution in those muscles. Once you've found the right position that they can actually feel muscle working in their thoracic back, now you know you got the idea. This is not a stretching exercise, although you are getting lat stretch here. So I might do one arm. I'll always stretch my lats, are extremely tight. This is really a way of stretching the lat and then facilitating the extension with those erector spines we talked about in the thoracic region with the lat stretch. It's a great exercise, but I don't do it in the beginning. I do it as I facilitate movement of the thoracic spine through this program. And then again, I keep it loaded, and we talked about the contribution that the thoracic back has in lateral flexion, tremendous movement of lateral flexion of the thoracic spine. So the windmill is one of my favorite exercises for thoracic mobilization for someone that's capable at that level. People that are extremely kyphotic, forward head, and they're stuck there, I usually won't put them on a windmill for a while. I'll work on mostly the floor patterns. But if someone can get into, especially someone that can get into good extension, flexion or horizontal flexion of the arms, and and it's tight, but this is a great way to facilitate movement of that thoracic spine up and down. By spreading the feet apart, position 1, 2, 3, and 4, we're actually changing the contribution. So think about this. As the knees, feet are together, like our toe touching pattern, the femurs are actually a little bit more rotated. So as someone's feet are together, they're not going to have as big of an arch. Or you can just spread your feet apart real wide and feel what happens through your lumbar spine. We're taking the femur, the head of the femur out, which is going to externally rotate the pelvis, or externally rotate in the pelvis, which forces, and there's a muscle pulling all this, which forces the anterior tilt. The adductors get really tight, pulling on that anterior tilt, which is hip flexion. You're getting that contribution of extension. So what we're doing is we're actually changing where that level of movement of the spine occurs by spreading the feet in the different positions. So it's a great exercise to work on. And then I'll actually add to that a challenge to that by bringing the hands behind the head with the chin tucked, elbows back on the wall, head back on the wall, and then tilting to the side. You're gonna take the lat out of this. You're gonna actually create some lat pull stretching. I don't like calling it stretching, but you're going to take the lat out of the contribution to that, and you're going to get even more. You're going to start feeling it even higher in the thoracic region. So hands behind the head, standing windmills is my go-to for just about anybody with neck pain, upper extremity discomfort that can get into this position. It's very hard, especially to tilt to the side and keep your elbow back without rotating or bringing that elbow forward, because the lat is being pulled. So if someone can keep their elbows back, keep their hand on the wall, this is a highly effective exercise if you've mobilized the spine up to this point. And then I'll just do something at the end to lock it all in. We've got thoracic extension. We can use the glutes, abdominals again to establish that lower cross syndrome, and have some way of supporting all this mechanism. Again, using the lower body to support that new mobilization and position that the thoracic back is in. I'll just caution you on this. There's a lot of stuff about thoracic mobility on the internet, and a lot of great examples of thoracic mobilization. But if you don't understand why it got tight, and if you don't have a way to address what you're taking away, so think about it this way. A house has this strong foundation that holds it up. And if the foundation starts collapsing or breaking down, you can put a lot of stilts around that house. You can compensate for what the foundation isn't doing anymore, and that's fine. But if you take away that compensation, you take away those stilts that are holding the house up, the foundation is still weak and the house is going to collapse. So you can do a lot of great work to get thoracic mobility, and there's a lot of great stuff out there, but you have to go back to understanding why it got tight, and you have to give the person something to walk away with. No pun intended. You have to give them something to support that new positioning that you're trying to achieve. You can get a lot of movement out of the thoracic spine through the right movement exercises, but if the body doesn't know what to do with it, it's going to go back to its compensation. But remember, they're holding on to thoracic tightness for support. And if you take their support away, you're going to leave them with nothing, and you're going to actually throw them into more of a spasm, and this is what we've seen a lot. So leave them with some stability stuff. I'll actually add one more exercise in here, one of my faves, to do with a lot of people, which is the air bench. And give me 2 seconds. I may even leave them with an air bench at the end of everything, just to solidify where we want the body to be working from without any contribution of the upper back. Stronger the lower extremity is, the more the upper back is supported, okay? People that exercise a lot, like I do, and I'm very cautious about how much upper body exercise I do, and I'm very aware of connecting that torso to the pelvis through my exercise patterns. People that isolate upper body exercise tend to have a lot of dysfunction between the lower and upper extremity. So I always leave people with some way of adding to the lower extremity contribution of stability to what we just gave them, took away from their upper body's support. Hopefully that makes sense. That's a standing rotation pattern, or sitting rotation pattern, I'm sorry. And I think you should be getting a pretty good indication now how all these patterns work and what they're telling us leading to the next one. That's all I got for you. All right, guys, thank you. All right.